month, we are fortunate enough to get the senior faculty members across the country, and with their experience, they have been sharing their views on different topics related to hip and knee. The whole idea is to spread this message to all the FNB, DNB fellows, the young surgeons, the senior registrars, and those who have just passed their MS. And every senior faculty has been putting a lot of efforts to give us their opinion, talk, experience on the various subjects. The next meeting is on the 9th of December. We have Dr. Vijay Bose and Dr. Neeraj Shah talking on the hip and knee subjects respectively. That's going to be the 9th December, the first Saturday, same time, 7 p.m. Today, we are very fortunate to have senior faculties, Dr. Javahir Pachore from Ahmedabad Shelby Hospital, and Dr. Vidyanand Rauth, the knee surgeon from Mumbai Wockhardt Hospital. So the first topic is going to be on the hip, which Dr. Pachore is going to talk on protrusio acetabuli. Dr. Pachore is all of those, if you don't know him, for us, he is the guide, mentor, and Bhishma Pitama of the Indian arthroplasty. I am not exaggerating these words. He has been putting so much of efforts to bring up the academic level of the ISHKS program, and he is the pioneer to bring out the Indian Joint Registry. As an young surgeons, you must have read about Australian registry, Swedish registry, Norwegian registry. Dr. Pachore is the person who has been contributing immensely in developing the Indian Joint Registry. And therefore, for many of us, or almost all of us, he is the Bhishma Pitama of the hip surgery. All of us have learned a lot of things from him, and he's very, not nationally, but internationally also very known figure. His contributions in the field of rheumatoid, ankylosing spondylitis, protrusio acetabuli is immense, and he has published many papers. He has been awarded a number of orations, including the ISHKS oration also. And currently, he is the professor and academic guide working as a department head of the hip surgery at the Shelby Hospital, Ahmedabad. Dr. Pachore, may I request you to share your screen and give your talk. Welcome, Dr. Vikram.
Good evening to all.
Yes.
Can you see the screen?
Yes. Yes, we can.
Yes.
We can
Yes,
see.
I can see.
I can go ahead.
Yes, please.
Yes,
Thank you
please,
for
sir.
introduction. The main idea of this lecture series or academic section is to spread the knowledge to the young orthoplastic surgeons. That was the main idea of the ISHK academics. So I'm going to talk on THR in protrusio acetabulum, and especially rheumatoid and other conditions. And this is not my work, this is a team work at Shelby. It is a hip joint deformity in which the medial wall of the acetabulum invades into the pelvic cavity with the femoral head. And this is caused by primary idiopathic, inflammatory, secondary neoplastic, infection, traumatic, metabolic, and some of the time genetic disorder. First, actually, it was described by a German pathologist, Otto. That's why it was sometimes called as an Otto pelvis. Primary remains the diagnosis of exclusion, and there is a possibility is that could be inflammatory or destructive. There is a quantitative deficiency of the vestibular bone, or a development anomaly of the growth disturbance which leads to primary protrusio. You can see the varieties of secondary protrusio are due to osteomalacia, renal pathology, post-acetabular fracture. In our country, tuberculosis and rheumatoid is much more common. And this is one of the classification has been described by Dr. Dholakia. In ankylosing also, 7% of the patients can have a protrusio. And this is also recently we have done analysis at Shalby Hospital, and this is something is around 9%. Sometimes we have a pathological protrusio because of the cancerous condition, and genetics. Sometimes you get Marfan syndrome. Also, you land in protrusio. The protrusio actually in rheumatoid is present as a unique challenge due to medial wall which is deficient, along with a severe osteoporosis, and there is no remodeling possibility. So incidence in rheumatoid arthritis protrusio was 15 to 28%, slightly more in our country, and it's around 20% plus. So this is one thing we have learned from out of our own patient example, how the medial wall heals. This was described long back in 1932, but we didn't realize. This is one X-ray showing 90, 92, 94. As the protrusio takes place, the trochanter hits the lateral wall and medially it starts healing. This is what how the healing takes place, because there is no stress on the medial side too much, so healing can take place. So this is something sometimes a natural history of protrusio. How do we measure this protrusio? We have three important landmarks to measure the protrusio. One is a Kohler's line, which is very common, which we use. Normally, we take a straight line, but it is not a straight line. It is a little curved line. Kohler's line is an ISHKS line. Any cup remaining inside on the medial wall 2 millimeter is considered as an early protrusio, and is a very practical. Second is Gates teardrop method. This is much more accurate when we want to check the medial migration and superior migration. Teardrop is always identifiable in revision condition also. So you draw a line, vertical line, teardrop. Another line is a horizontal line, and this will give an idea of medial migration and superior migration. Is very, very important as per that. And Ranawat method is used to know the precise location, which I will tell you. The whole pelvis X-ray has to be taken, and interischial line to a top of the iliac crest. We measure this and divide into 5 parts, 5 equal parts. And from teardrop, we will take one part of that fifth and another horizontal we will do it. And that is known as precise location of the acetabulum, where normally we want the acetabulum to come as, and that is called isosceles triangle of Ranawat. The classification early described by Scotolo and Charnley way back. And if it is less than 5 millimeter, we call mild. If it is 6 to 15 millimeter, we call moderate. And it is much more than 15, we call as a severe protrusio. And these are a couple of examples from our own database. We require a very good imaging for these patients, because most of them are osteoporotic and they are deformity. So we need a good imaging for these patients. And when there is no medial wall deficiency, we might require a CT scan for these patients. And that will give an idea of the medial wall deficiency. So normally, difficult radiological radiograph, visualization is always intraoperative on CT scan. The medial wall was classified again by Charnley. If it is less than 1 centimeter or it is more than 1 to 3, if it is more than 3 centimeters, there is a pelvic dissociation, and this requires different treatment than in my type 1 and type 2. That we will come to it. So this is the CT scan of the patient. You look at this complete non-union of that area, and the transverse sections are more important, which I'll show you a couple of them. This is the post-acetabular fracture. If you look at the transverse section, you look at this medial wall is very, very thin. There is a 2 area of non-union, but less than 1 centimeter. It is a fibrous type of non-union, and this will just require multi-hole cup and bone grafting, and that will heal. There is no dissociation in this patient. So regarding this biomechanics of this rheumatoid protrusio, this is abnormal bone I told you. Usually it's a progressive and a gradual. Hastings and Parker say 2 to 3 millimeter, but Ranawat came on the mind that is not only medial migration, it is also superior migration. So that's why these cups are slightly sometimes go in the high center. That's why we need to ream slightly on the low position to bring into normal center of rotation. So preoperative planning is extremely important, good imaging, and you need a good preoperative planning to know interischial line, how much superior migration, how much is the medial migration. We'll try to do this preoperative planning very meticulously. And that's the same patient post-op X-ray. Many times you will not be able to bring us to the normal center of rotation. Maybe a 2 or 3 millimeter or 5 millimeter will remain because these patients are very tight. Soft tissues are contracted because this is a long time process. This is a very chronic process, and that's why reduction sometimes is always difficult. You require extensive release, and that's why posterior approach is better for all these rheumatoid with protrusive patients. And many times you require adductor tenotomy. You can see in this patient, there is a clip on the medial side that indicates the adductor tenotomy has been done. So 2 to 5 millimeter of anatomy disturbance, it doesn't matter because these are low demand protrusive patients. Sometimes you can see this is the type of with a non-union and type which has been brought back to the normal, but still the 5 millimeter of proximal migration is still there. So you require a good exposure. Posterior approach is recommended. Keep a watch of sciatic nerve. Very important for all of you that this nerve, as the protrusive takes place, usually the sciatic nerve is pulled towards the femoral head, and that's why it is very, very close. You need to protect it with your fingers or something. But don't expose, no necessary of exposing sciatic nerve in this approach. Stay away from the nerve, otherwise you will damage. In these patients, most of the time we keep the capsular flap intact, but sometimes you need to excise the capsule in this protrusio. Excise labrum or 2 to 3 millimeter of posterior osteophyte you can sacrifice for dislocation. If you are not, then you don't do any forceful rotation. One important message, the surgeon should dislocate, not assistant, because you know how much release you are doing, there's a titrated release is required. As you know, you release, try to see the femoral is coming out, is not, release again. And if at the end of every release, if it is not, then you do a subcapital neck osteotomy. It is called napkin ring osteotomy, which I'm going to show on the video. What is meant by napkin ring osteotomy? You need to normalize the center of rotation as much as possible. Keep all possible protrusive device ready because once in a while you can have surprise. As a hip surgeon, you must know the trochanteric osteotomy. In this patient, the protrusive was iatrogenic because of the bipolar, and you cannot cut the neck of this way. It is the metal neck. You can't cut it. So if you can't see the neck of this prosthesis, you need to detach the trochanter, and you must know how to do a trochanteric osteotomy. This is such a patient who had. You can see this is the trochanteric osteotomy. Take a large piece of trochanter because then the union becomes better. You use the saw in the intertrochanteric area where from the vastus lateralis and release the whole of the anterior capsule. You can see the whole anterior capsule is in front and you should be able to dislocate. So this is one important thing which as a hip surgeon you must know, and that then the job is easy. This is socket privilege. This is the most crucial of the in the protrusio. If you know how to prepare the socket, I think 70 to 80% battle is over. So we need, after dislocation, you need to check the defect, which I'm going to show you on the video how we check the defects. Preserve subchondral bone. Don't ream the medial wall at all. The reamer should not touch on the medial side. It is only the mouth has to be opened up. So it is something like bottleneck, which has to be opened up. And expansion in narrow position, low position, and that's why you get the normal center of rotation. So most of the time there is a superior migration has taken place. If you try to get the ream them superiorly, you will go into high center, and there is a difference between the superior and inferior configuration and anterior posterior configuration. There's a mismatch. So if you try to do excessive reaming, you will lose the anterior or posterior wall. This is the most important thing to watch all the time, anterior posterior wall. So consider reshaping the acetabulum, create normal center of rotation, achieve acetabular stability, and soft tissue balance is again important. That's why you require a lot of soft tissue release and adductor tenotomy in these patients. So the less than 5 and good medial wall, you don't need require, you straight away go. More than 5 millimeter protrusio, reasonable medial wall, just grafting is indicated with multi-hole cup. And much more, if there is a dissociation, then you require additional fixation. One important message, object of protrusio is lateralize the cup, normal center of rotation, and strengthen the medial wall. This is most important thing, which was described by again Ranawat in 1986, and we just follow these principles. If the center of rotation is not restored, if it is restored, it is a loosening rate is 8%. If it is not restored and more than 50% patients will have extremely high chance of loosening. So you need to get a normal center of rotation at most. So sometimes this is something the old fracture acetabulum, superior migration. It is but sometimes we need. If you look at the lower figure, that is a normal round shape acetabulum, and that is the oblique. So the anterior posterior diameter is smaller, and superior inferior diameter is much more larger, and you can't compensate this. This is the patient you will need what is called high center, or put acetabular graft or a wedge and bring it down, because you can't play around the anterior posterior wall. They are very, very thin. Up to 10 millimeter of high center. This is one of the patients with a 5 years follow-up, about 10 millimeter higher center, and she has done extremely well. Look at the bone consolidation has taken place, and she has almost normal function, except maybe a mild limp. This is what we do the preoperative planning of this patient. This is the protrusio. We mark the ilioischial line. This is almost grade 3, but the medial wall is good. There's a whole wall has been calcified, so there is no major worry except the small defect will be there. We will look at the femoral part. Here you need to cut the neck little longer because it is difficult, and also you need that graft for the grafting. So you have a modularity. That's why instead of cutting a little on the lower higher side, you cut a little on the lower side, maybe 2 millimeter. This is important to see under anesthesia how much movement patient has. If he has good rotation movement, then you will be able to dislocate. This is what we are using a posterior approach, which I told that's a preferred approach for such a difficult patient. This is another important thing. You just cut the fascia and don't enter into the muscle. Just cut the fascia, and after cutting this fascia on the TFL, and then you split along the fibers of the gluteus maximus, the bleeding will be less. Palpate the sciatic nerve. I just doing the palpate the sciatic nerve. Don't expose. And now you need to detach the gluteus maximus. That is the first step for this patient. So whole of the gluteus maximus is detached from the insertion, and then use the very closely. You take the periosteum. And also protect the periosteum of the sciatic nerve behind, and just start around the very close to the bone, and that's the superior capsule. I am incising the superior capsule, and I'm able to now see a part of the neck. Can you see the neck completely? Now this is known as a napkin ring osteotomy. 1 centimeter of the whole neck is taken off. Reason is, if you just cut it, chances of spiral fracture are high when you are dislocating. And that's why you take out that 1 centimeter of that bone from the transcervical area. This what I have most important is to release the rectus. And once there's a glistening structure. Once you've done that, anterior retractor becomes flat. Now I am still not able to take out the reliever of the head, because you see the completely the mouth is so small. So I tried to use the Steinman pins and try to deliver. It was impossible. So what we did was we used a thin saw, a reciprocating saw. We cut into 4 portions and tried to take out one of the portion. So still it was not possible to take out the complete femoral head, because the mouth was very 36 millimeter. There was no possibility of taking out this. So we decided to start a little bit of reaming and opening the mouth, a little bit opening the mouth, so that which may allow us to take out the other portion. So I started with a 36 millimeter, and tried to use a little, open the mouth a little bit. So 36, maybe 40, 44. I was very gentle in opening the mouth area. Now you can see, now I'm able to see now the femoral head there, and with a towel clip or something which is possible to deliver. Now I was able to deliver this and keep this bone preserved. Very important, because you need a graft for this. And once you're done, take the K-wire and see where the defects are. You see there's a small defect there. You can see the blood there. That is a small defect. Then you start reaming according to some degree of anteversion, maybe 20 to 25. Look at the torso here. Tail may not be visible at all. So look at the torso and start reaming gradually. Only mouth, no medial wall at all. Medial wall only to be scraped with a scoop at the last end when you put a graft. So very gentle reaming. Try to see that you are watching the anterior and posterior wall so that you don't damage. This is the most important step, because you need a periphery. Otherwise, the cup is not going to be stable. And you see this, the 48 size cup has gone very well and it becomes stable. We left the handle and it is very, very stable as well, because periphery has been kept intact. These are the graft. We don't use morcellized graft. We use a mastic graft. And our sisters are very expert in keeping this slurry graft on. Don't put all the grafts at a one time, single time. Put little, hammer with a ball tip, hammer the pusher, and then again put little more, again put little, so that you get a good impaction. And this is important again. Take a smaller size of the trial implant and see that how much graft are needed. If the graft if the cup goes right inside, you need additional graft. If comes out, that means you take out the graft. The another important is now reverse reaming. This is the reverse, very slow speed reaming. Slow speed reaming. Don't put on the drill; it is put on the reamer. See how good impaction has taken place. So the graft gets impacted with the reverse reaming, and then you take the cup. Probably 3 holes are enough for him, and once in a while you might require a multi-hole cup. So keep ready, everything available. So you see that and this is the poly cup coming inside, and then on the femoral side is not the problem. Usually these are wider canals in these patients. You should not have a problem, but you should keep an option of cemented stem available on the shelf, and which usually we have. And that is a reduction, that is a combined anteversion. We can see 30 degrees of anteversion. These both are parallel to each, the head and as well as the poly, and head not dislocating. And the posterior capsule is still okay. And this is the post-op X-ray of that patient. So there is quite good job done. These are some patients from the Dr. Dhanasekar unit at Bombay Hospital. This is what my boss did at that time. There we had no technology, and this is a 20 years follow-up of his patient, and it sustained well. It is a cemented cup, but it was a mild protrusio. In a moderate protrusio, we did had a very high rate of failure, and that's why we stopped actually doing the cemented cup in a moderate protrusio, because there is no cancellous bone available. This is one of his patient, 8 years follow-up, and loosening has taken place at 8 years, which is not accepted. So what people decided, the Tom Smoo group, is we use the morcellized graft inside, and then on that you put an eccentric cement and use the flange cup. We didn't had a large experience, but we did a couple of them initially at the Dr. Dhanasekar unit. This is one of his follow-up at 1 year, a cemented cup with a morcellized graft. And this is something some 7 or 8 years follow-up of one of his patient with a cemented cup and medial grafting, consolidated well. But technically, I think it is a very highly demanding. Probably we will not recommend that. We will not recommend this procedure, because we have some biological options available. And today we have so much of a good biological option, because the porous coated cups are extremely doing well in protrusio. So we'll put a slurry graft, which I just showed you. We do reverse reaming and put this uncemented cups and put a couple of screws. Always protrusio will require a couple of screws, at least minimum 2 to 3 screws. and if required, ISHKS screw and pubic screws. So this is just example of uncemented cup. Uncemented cup, that's a Mosher type of cup, 8-year follow-up and was completed. You see how beautiful consolidation has taken place along the ilioischial line. This is one iatrogenic, that is the bipolar, soft bipolar, severe protrusio. This was 11-year follow-up of this lady, and this is 20 years follow-up. She started dislocating. So we have to change her cup and put a dual mobility on this. So this is 20 years follow-up, but we have to take out the cup because there was no modularity available. So this is another, what we are talking about. These are the poly cups, morcellized, but we now don't use this. We use the modular cup. And this is one example of a patient. You see, this is almost like a little non-Indian at that protrusio grade 2, grade 3. And this is a CT scan of the patient. This defect is less than 1 centimeter. So, and this defect is not a dissociation. And what we have done is a porcelain slurry graft and uncemented cup. And see, look at how the beautiful healing has taken place of these cups. So this is another patient from our own unit at Shelby. Look at the medial side. Looks to be that the medial wall defect is too much. But CT will give a great idea. You look at the posterior wall is thin, but very carefully, if you look at the transverse section, the dimension in the non-Indian is only less than 1 centimeter. So we decided to just use a morcellized graft, a mastic graft, and use the multi-hole cup, and that will heal. And this is an example of this lady at 4 or 5 years follow-up. Look at that. The whole biology is restored. So complete healing has taken place. So what is required is a graft and stabilization for these patients. This is one example we learned what we should not do it. This is from, again, Dr. Dholaka unit case. This was the medial wall was completely gone. So the whole head was slightly inside. And in this patient, you can't use a multi-hole cup, it will fail. And this is the patient who has given her experience that you should not use when there's a dissociation, you should use either cage or something else. And this is what we learned from this own patient. So within 4 months, she dislocated, and we have to put the cage. And this was probably a second cage in the unit at that time. The new technology is coming up with the difficult cases like a protrusio of this type of, sometimes we do use what is called 3D printing, and this is available very next door to Ahmedabad, and we do it routinely in a difficult cases. Something like this patient who had this problem, we wanted to see the defect. You can see this is a plate there, and you can play on this very well. And the surgeon becomes very confident to go inside and do this surgery. The confidence levels goes high. You can play this outside the theater, ream it, see the size of the what cup, where will be the screws are, how much grafting is required, or whether they are non-Indian required, anything else. All this can be tackled on this tackle. You can see this, what we have. We have done this outside the theater, and that's the follow-up of this patient. The whole thing is united extremely well without touching any plate or anything, just grafted on the medial side with a multi-hole cup. And this is also another example of such a nature of a very bad, hardly anything which is on the medial side, and as well as the paper thin wall. But these cups will do extremely well. You see how the reconstruction has taken place. Here, the dissection was very difficult, so I had to do a trochanteric detachment for my exposure, and that was possible to do it. And you see how the trochanter has beautifully united and how the medial wall has reconstructed. This is almost about 7 or 8 years follow-up of this patient. So these are types of remodeling. You can see them on a post-op at 3 years, 5 years, 10 years, all that. So this is sometimes 1979. We had no technology, and that is the time we did a cemented cup with a protrusio. But like this lady, low demand, survived for 22 years, and suddenly one day it went inside the medial wall, the hood broken on the medial side, and we had. This is the intraoperative picture. We had to put a cage, and this is what we learned from actually Wheeler unit. Myself and Sanjay Agrawala went actually to the Wheeler unit to see how to how to put the cage, and we learned from their experience. So we have to the steps of operation is the thin medial wall on that side, and then you put a the slurry graft. Over that you put a cage. Over that you put a very thin layer of cement, and you put a poly cup. This poly cup should not be in the direction of the cage. It should be independent. So otherwise you will have a large area, number of dislocations. You have to put the cup anteversion and transverse. So don't look at the cage. Look at the torso. Look at the Chanley acetabular holder. This works beautifully. A Chanley acetabular holder to manage the acetabular cup, especially for this condition. So a very important step of this. Otherwise, you will have a large dislocations. So these are some of the cages. How beautifully these cages are likely to fail at 10 to 12 years. But we created the bone for the revision surgeon. I had opportunity to take out these two cages in Shelby, our own cases, and I was able to put a primary cup in this group of patients. So we have created some bone here. This is another protrusio inside. Whole thing, there's no medial wall at all. More medial wall, and this is what 11 years follow-up which we have done. Recently, this lady died in 2020 after the COVID, unfortunately. So, but I have an 11-year follow-up of this lady, and look at this cup which has been put. So this cup is transverse, and look at the build of the cement which is there. And this is what is important. Cage is looking layered distal down. If cage was not cage would have been covered with this, the cup would have been vertical and she will dislocate. So very important step of this operation. Don't look at the cage, look at the torso. This is one more. We did had a now newer technology is emerging. We do have what is called as a cup cage and as well as uncemented cages available in India. This is from one of the company which we had opportunity to use one of our patient. This was an abduction, one side abduction deformity, adduction deformity rheumatoid. And we did a good job, but the cup was vertical. We didn't realize that patient has an abduction deformity. Once this abduction deformity gets corrected, the cup becomes more vertical. Again, we learn from this patient. And this cup became vertical after her correction of pelvic obliquity. And she started dislocating. We did a CT scan. We saw the anteversion was too much, and cup was vertical. So we decided to revise and put a cup a little transverse. And we were very unfortunate for this girl, and this was not stable, and she almost went inside. So we did a CT scan, we did a model, we did a modeling, and we did a vascular study also, and we kept the standby surgeon, and we were able to do a good job of uncemented technology using this cup type of cage. And you see, look at the 3 years follow-up. She's touched wood, she has done extremely well. Alignment, limb length, everything is fine. So this is another technology. Sometimes do have complications with the protrusio. This is the one of the surgeon was operating periphery and the whole thing was went off. He didn't realize the whole cup dislocated up, and he didn't even use the screws in this. That was one of the mistakes which we had, and then he has to put a cage. He has to put a cage. The second example was straightaway the day one failure happened, intrapelvic, it went, and we have to put a cage. And look at we did an adductor tenotomy. This soft tissue release also was not enough for this patient, which we have to do it. So this is a more biological solution. Only the cost is the biggest problem, but this is an extremely biological solution for difficult pelvic dissociation. It is biological. Is an ischial weight takes place, supports the porous coated cup, and osteointegration takes place. We don't have a very large experience as far as these are concerned. But this is one of the important solution for the cup cage. And 3D customs are now coming up. We are lucky. We are got now in India itself. There are various centers. We are able to give. They are able to give within about 3 to 4 weeks the customized implants for a very difficult situation like this. What are the long-term results of this protrusio are? The cemented hips have not done well. The 50% loosening, but this was the initial old data. But with the bone grafting, I think data is much better. So if you look at the impaction and cemented cup, they have done it well. So 90% survival at 12 years, which is not bad. So uncemented, they're doing well. This is 7 years follow-up of only 2 aseptic loosening. I think today the technology for uncemented, highly porous coated cup, which will be better off with us. So the comparison was taken between cemented and uncemented under the age of 50, and the inference was uncemented were very superior biological. So in summarizing, good exposure, identify bony deficiency, more than always radiology, very careful reaming, lateralize the cup, normal center of rotation, strengthen the medial wall, and must achieve cup stability. Don't leave without screws these cups, whatever the stability you get. Mild to moderate, these are medial wall augmentation I just discussed. Uncemented cups are much better. And very severe and dissociation, I think you need elderly patient, you can do anti-protrusio cage, but slightly younger patient, high demand patient, I think you should use cup cage that is much more reliable. I must thank my the team. This is not a single man's work. I'm very thankful to the Shelby team for doing this work. Thank you for attention.
Thank you, Dr. Pachore. I think it's like a chapter of the book. You have extensively covered. By the time we get some questions on the chat, I have a couple of questions to ask to start the ball rolling. How often do you use IITV on table?
For protrusio, no.
Okay.
For protrusio, no.
If there is a small defect, you said that majority time we put the graft. Do we ever use a small mesh or something to support that graft?
No. We have stopped using the mesh. Reason is we want a biological solution, so the defect is there. We are lucky we have a bone bank. So what do we do? Take the femoral head, take a good slice, and that slice acts as a mesh.
Okay, so mesh is not advised. Okay, mesh is not advised. Right. And majority of the cases you showed with the bone graft. So what's the weight bearing protocol?
Protocol, I think 6 weeks they are 6 weeks at least minimal. They are protected by walker, and they're hardly using a weight. Just maybe a tiptoe if just mobilization is important. So full weight bearing only after 6 weeks.
Okay. Can you look into there is a question answer. There is one I can't open from here. Dr. Pachore, can you have a look at the question?
I hope so. I will be able to open. Yes. Can you shed the light on preparation of the bone graft? Okay. These are matchstick graft. We stopped using morcellized graft. We used to use take the acetabular reamer and graft that graft we used to use. So these grafts don't have a mechanical good stability, and most of the osteogenic property goes off. Second very important thing is after the graft have taken, please wash this graft beautifully till they look like a white. You should take out all that fat material inside. This has been showed by the German paper, 1 or 2 papers, that you need to wash at least 4 or 5 times, and then we put actually a little bit of antibiotic, vancomycin or something, and just then put the graft. So this graft are slurry graft, matchstick graft 1 centimeter, maybe 1 centimeter, 5 millimeter, 5 millimeter or so. And use the nibbler and don't use the saw for the thing. Use the nibbler, mechanical. And I'm very fortunate. Our sisters are very experienced, especially for the knee surgery. We require so much, not for the leg. And one separate always team is there.
I would like to add one thing. I would like to add one thing here, that whenever grafts are washed, they are large pieces of chunk of pieces from knee replacement, that is notch cut and the tibia cut, and then that is washed with power jet, which is used to clean the knee when we do knee replacement, number one. And when the small pieces of bone are done 5 mm to 1 centimeter, those pieces are put in 50 to 60 degrees centigrade saline, so that fat comes out, because with a little higher temperature fat becomes liquid. So we use little warmer saline so that the fat comes out faster. That's it.
I think that is the principle of using the bone bank graft. I think every time we should use the warm saline, use the vancomycin, take out the fat, and make it as white as possible, as Dr. Pachore just said and you mentioned. So for all the bone bank graft, we should take all this care, and there has to be a separate team to prepare that. Any more question, Dr. Pachore? Can you hear?
I'm okay. I can hear, but I'm okay to answer anything.
Okay.
Whatever the best is possible.
Can I ask
the example which you showed, that the mouth was 36 and very slowly rimming it, you brought it up to 48.
Yeah.
Correct. So that means that majority of the time the mouth is very small and you have to be very carefully start rimming it, expanding it till you get this primary stability from the two columns.
Yeah. You always watch what is happening anterior posterior.
Sir, can I ask one question?
Yeah, sure.
Yes, Dr. Rauth.
Okay, sir, if we have a bipolar which has protruded inside and the head is completely inside in the pelvis, so how often do we need an ETO to get it out before reconstruction?
Yes. One thing, after releasing soft tissue, if you are able to see some part of the prosthesis, I just detach the trochanter and then I am able to deliver. If I am not, only in my life, only one case I had to take out from intrapelvic. That is at about 4 or 5 years back. I have to call the pelvic surgeon, and we are lucky that we have a pelvic surgeon in Shalby, and they were able to do it for me. Then I went laterally, then I went posteriorly and did the job. That is the only case.
And in those cases, you usually go for CT angio also.
Absolutely. Any of this revision situation where the intrapelvic cup is there, you must do angio, and you keep your colleague standby. And we are lucky that we have a cardiac unit.
A couple of more questions, Dr. Pachore.
Yeah.
Can you just see?
Yeah, okay. Reverse rimming principle. It gets the graft gets uniform and gets impaction. That is a principle. There is one more, Nishant. Do you accept a single axis stability in this complicated? Yes. If it is a rheumatoid and periphery is intact, you will get all the stability. In revision situation, you may not. But in primary rheumatoid, you will be able to get, because the mouth, the peripheral is totally intact. So you will get a stability. But in revision, you may not. You have to rely on one stability. Definitely, yes. Revision situation, you may not get that fantastic stability. When do adductor tenotomy? Adductor tenotomy, I do it once the patient is turned. In patient is turned, then if I don't get the 20 degrees of abduction with anesthesia, I will do tenotomy. I have my own slight different way of tenotomy. I don't do a closed tenotomy. I take a 1 centimeter incision on adductor longus. I see the glistening structure. I put my skin hook and lift it and cut it. So I am 100% sure it is not a closed technique. It is an open technique. So that is what, and I have no hematoma formation as far as the adductor tenotomy is concerned.
But do you think that after doing the adductor tenotomy, it is sometimes your stability part may change? Can that happen?
I don't think.
Okay.
I don't think. Many surgeons after anesthesia, if there is a very severe adduction contracture, they do adductor tenotomy first because reduction becomes easier. That I have done very few, once or twice only, mainly for ankylosing spondylitis and other conditions.
Yeah. I think there is one more question, and then when we can move forward, Dr. Pachore, there is one more question.
One more. I don't see here.
Right, yes. Sir, is there a role of dual mobility?
Dual mobility. Yeah. For rheumatoid, revision, yes. Not for rheumatoid straight primary, because they are low demand patients. That is okay as far as this is concerned for dual mobility. But revision situation, yes, multiple revision situation, patient who are spastic, patient who are Parkinson plus, these are probably patients for a dual mobility or a revision situation where there is a possibility. Otherwise, no. But for dual mobility, abductor has to be intact. Deficient abductor, dual mobility does not work. Then you have to go on a constraint.
And most of the time in primary, you don't need cup like trabecular metal or gription or anything.
Oh, to be frank, you need a better porous coating. So I don't want to name the implant companies, but you need a better porous coating. So high frictional is better, definitely better.
Okay.
Only problem is the cost factor.
All right. Okay. I think we should thank you. Dr. Pachore is not in Ahmedabad. He is sitting in a very remote place in Rajasthan, and you can see the makeshift arrangements in his room he has done to give this a beautiful lecture. So, Dr. Pachore, on behalf of the Education Committee and the whole of the ISHKS team, we thank you for this excellent presentation in a very difficult physical situation you are. We understand that, and I, along with Dr. Raja, Dr. Vikram, Dr. Sharan, we thank you for this beautiful talk. Before we go to the next topic, I would again remind that the next session academic is on 9th of December, where we have Dr. Vijay Bose going to speak on the acetabular revision part, and Dr. Nilesh Shah from Mumbai, the patient satisfaction after TKR. So these are the two topics for the next session, which is on the 9th December. After that, in January, we have Dr. Leo Joseph and Dr. Krishna Kiran. The reason I'm saying all these things, that we are fortunate to have very eminent senior faculties across the country, and they are very willing to come forward and contribute their knowledge and exchange their views with all the young surgeons. So with this, I thank Dr. Pachore and request Dr. Vidyanand Rauth, who is the next speaker for the knee. Dr. Rauth is a Bombay-based surgeon attached with Wockhardt Hospital. He did his MS from KM Hospital. He's a Ranawat Fellow, did his fellowship in US, and after that, he spent good time in Australia at different places for his advanced training. And his top is the fixed flexion deformity, the FFD, when you do the TKR. So, Dr. Rauth, can you share your screen? And
yes, sir.
Please the talk.
Dipak, can you excuse me for going for a down? Because
Thank you very much.
Thank you, Dr. Pachore.
Dr. Videsh, sorry.
No problem. I know. You are in the middle of a meeting and you have come out of that. So thank you very much. Thank you. Thanks.
Thank you, Vikram.
Yeah. Dr. Rauth, can you share your screen? Dr.
Yes.
Pachore, you need to stop sharing.
Yeah.
Okay. Can you see my screen?
Yes, we can.
Okay. So thank you all and pleasure to be here. Excellent talk by Dr. Pachore, sir. And I'm privileged to have this opportunity to interact with all of you. So getting right down to it, total knee replacement in fixed flexion deformity. Now, this is a very common condition. Okay, so if we see an X-ray like this, a preoperative X-ray like this, I mean, we immediately know that these humongous osteophytes are going to dominate the entire knee replacement surgery. I mean, this patient obviously is going to have a lot of flexion deformity. Look at the posterior osteophytes. And so we need to tackle this in a very organized and algorithmic manner. Flexion deformity in total knee replacement can present in various degrees. So, gentlemen on the left, you can see that this is a mild flexion deformity, 10, 15 degrees, very common and very easy to deal with. Whereas on the right, we see a patient who has got a 65 degree flexion deformity, and that requires a lot of work to be done at the back of the knee. So this is a simplistic classification of flexion contracture. Mild is less than 10 degrees, moderate is 10 to 30, and severe is more than 30. So the bony structures that you need to tackle when you deal with flexion deformity are posterior osteophytes, anterior bony block, and maybe loose bodies in the knee. And the soft tissue structures that you need to tackle are a tight posterior capsule, tight PCL, and sometimes in severe cases, hamstrings and gastrocnemius as well. So what is the problem with FFD? Why the big hype? The simple reason is that a patient with flexion contracture, the quadriceps muscle or the extensor expansion is at a disadvantage. There is quadriceps fatigue due to continuous firing, especially in severe deformities like 15 degrees or more than that, when a 20% more forceful contraction is required in the knee. This obviously leads to muscle fatigue, pain, decreased walking velocity, and obviously there is also some limb length discrepancy. So we have to correct the deformity during a total knee replacement surgery. How much do we aim for? How much do we correct in TKR? So, well, if it's an osteoarthritic knee, the general dictum is that we aim for full correction. Whereas if it's a rheumatoid knee, you may leave a 10-degree post-op flexion contracture. And this is because the rheumatoid knee is expected to get better on its own. The disease process is going to reduce. The patient is on demands anyway. And we can expect a gradual stretching out of the deformity on its own. So in rheumatoids, we can leave, say, 10 degrees or 5 degrees of flexion contracture. But in osteoarthritic knees, the aim is to achieve full correction. So are there any pointers or risk factors which will herald the possibility of a post-op residual flexion contracture? The most important risk factor is a pre-op flexion contracture. So if you are starting off with a 30-degree flexion contracture, post-operatively, the patient has a higher propensity to have a residual FFD. In addition to that, male sex and advanced age are also risk factors. So we have to be extra careful, say, in an elderly male patient with a 30-35 degrees flexion contracture. Surprisingly, as per these two papers by Stewart and Ritter, there is no effect of BMI. So obesity does not really play a role in determining if the patient is going to have a post-op residual contracture. But pre-op FFD, male sex, and advanced age, these are important. So this is a sort of a simplistic algorithm for correcting flexion contracture. So step 1 is standard exposure and soft tissue release. Step 2 is medial release and removal of tibial osteophytes. Step 3 is standard bone cuts. Step 4 is progressive posterior release and femoral osteophyte removal. Step 5 is additional bone resection if required. And step 6, which is rarely required, is tenotomy of the tight hamstring muscles. And this algorithmic approach will basically tackle any degree of flexion contracture, be it a 10, 15 degree contracture or a 60, 70 degree contracture. So we'll try to see this in more detail. First of all, we need to examine any deformity under anesthesia to see how correctable it is. Because, say, a 30 degrees flexion contracture in the ward like this, like on the left, reduces to a 20 degrees deformity under anesthesia. And 20 degrees is obviously more manageable. We know what you are dealing with. We know what you are going to expect. We know how much soft tissue release or bone resections we are going to need in this patient. So examination under anesthesia is important. Step 1 is standard exposure and soft tissue release. Nothing fancy here. Just employ a standard medial parapatellar approach. Expose the knee. Try to invert the patella. Get rid of the cruciates. Try to sublux the tibia in front. And do a general release on the medial side. Step 2 is working on the tibia. So we do a medial release and try to remove tibial osteophytes which are tenting the capsule. So this medial release is predominantly for correction of varus which is existing together with the flexion contracture. So most of these deformities are biplanar. So varus with flexion, or sometimes valgus with flexion. So in this case, what we are showing is a varus deformity with a flexion contracture. And when we correct the varus deformity with medial soft tissue release and medial osteophyte excision, part of the flexion contracture also automatically gets corrected. So what we need to remember is that we cannot over-release on the medial side. So if it's found to be tight, and we keep releasing, suddenly it gives way and it's too loose. And that will lead to a catastrophic loss of medial soft tissue support, medial soft tissue sleeve. And that will herald the need for hinged implants or constrained implants or a hinge, which we may not have on table. Step 3 is standard bone cuts. Tibial cut is standard 9 or 10 millimeter, whatever the system tells you. But try to keep less slope in tibia. So if you're a PS surgeon and you are used to keeping 3 to 4 degrees of slope, in a flexion contracture case, you would keep only 1 to 2 degrees of slope. Same thing, femoral cut is standard. Don't cut 2 millimeter extra at this stage. But if your experience tells you that in this patient, you are going to require definitely added femoral resection, you may save time by taking a +2 cut, but nothing more than +2 at this stage. Also, we try to upsize the femoral component. Why upsize? See, already because of the flexion contracture, there is a mismatch between the flexion and extension gaps. The flexion gap is, the extension gap is tight, the flexion gap is relatively loose. So we have to fill up the flexion gap. And one way to do it is to upsize the femoral component within the confines of the mediolateral border of the bone. I mean, we cannot upsize by more than 2 sizes. We prefer to do a PS rather than CR in a severe flexion contracture. So once the standard bone cuts are done, then we have a preliminary assessment of the flexion and extension gaps. Usually what we would find is that the flexion gap is all right, it is snug. With some of the available thickness of poly, we are able to stabilize the flexion gap, but the extension gap is found to be tight. Even the smallest available poly is not accommodated in the extension gap. So we are not able to straighten the knee. But at this stage, we get a fair idea of the mismatch between the flexion and extension gaps. So we know what we are going to deal with. This brings us to the all-important step 4, which is progressive posterior release and femoral osteophyte removal. Now, to do this step, we can use either a cautery or a 15-number knife, but both of these require guts because we need to work in the back of the knee, we need to work in the gutter. So my personal preference is to use a curved osteotome. So someone lifts up the femur and use a curved osteotome, try to get rid of the osteophytes in the posterior part of the femur. Good illumination is essential. Someone lifts up the femur from the top, someone distracts the tibia. We see the knee end on from the front. Use a broad curved osteotome, sharp osteotome, and get rid of the posterior osteophytes in the gutter. Once the osteophytes are removed with the help of a Cocker forceps or a nippler or whatever, then we use the same osteotome and try to strip off the capsule posterior from the posterior aspect of the femur. We can also use a combination of the osteotome with the cautery. So under vision, we can use the osteotome as sort of a retractor and try to cut the capsule with the cautery near the edge of the bone, near the posterior edge of the femur. So after this, once the posterior osteophytes are removed, then we assess the flexion and extension gaps again. Now here we would find that the mismatch it was there initially is now reduced to some extent. In many cases, this is all that is required. We may find that the flexion and extension gaps are balanced and we are able to get the knee in full extension. And if that is so, then we stop here. Nothing further is required. We just proceed with the finishing cuts and finish the TKR surgery. But if even at this stage, we find that the extension gap is tighter, then what do we do? then we come to the most important decision-making step, additional bone resection. Now, additional bone resection from where? From tibia or femur? So let's consider the tibia first. We can resect about 2 millimeter or 3 millimeter bone from the tibia. That's easy to do. But problems with too much tibial resection are that we are forced to go into the soft metaphyseal bone. As we cut more bone from the tibia, we go into soft metaphyseal bone, which may not be able to support the metallic tray which we are going to put in. Also, the tibia is conical in shape, so we are forced sometimes to undersize the tibial tray. And this sometimes creates a problem because, see, we have upsized the femoral component. And now if we are undersizing the tibial tray, there may be a component mismatch. Femur is too big for the tibia. That should not happen. The most important problem with tibial resection is its effect on the flexion gap, because tibia is common to both flexion and extension. So by resecting more bone from the tibia, we are not doing anything to correct the flexion extension mismatch. The only situation where we can cut tight due to upsizing of the femoral component and reducing of the tibial slope, the both gaps are tight. In that case, the simple solution is to cut 2 millimeter from the tibia, and that will sort of open up both the gaps. But in most cases, additional bone resection, if required, it must come from the distal femur. Now, problems with too much distal femoral resection are that it itself will lead to several problems. First of all, it will lead to mid-flexion instability. And this is because the collaterals no longer are isometric. So the tension may be good in 0 degrees, the tension may be good at 90 degrees, but in the middle range, 45-50 degrees, there may be laxity. That is classic mid-flexion instability. Also, elevation of the joint line will lead to a relative patella baha, because patella has now come down. And sometimes the patella can collide with the poly, and that also prevents an impediment to flexion. Another problem which may be seen is that elevating the joint line too much can lead to violation of attachment of the collateral ligaments. Now, this is not very common because the collateral ligaments are 2.5 centimeters away from the articular surface. So if the normal resection from the distal femur was 10 millimeter, we still have about 14-15 millimeters of bone left before we stray into the area of attachment of the collateral ligament. So +2 or +3 or +4 cut is not going to create problems. So correction of any concomitant varus by medial soft tissue release and osteophyte excision also helps to release mild FFD by an almost equal amount. So in many cases, if the FFD is less than 10 degrees, there is no need for any additional distal femoral cut. And the general dictum is that beyond 10 degrees, every additional 1 millimeter distal femoral cut will correct 5 degrees of flexion contracture. So how much of the femur, how much of the distal femur can we cut safely? So this is a rough guideline. If you are a CR surgeon, if you are doing a CR knee, we don't want to play around too much with the joint line. So maybe 2 millimeter or maybe sometimes 3 millimeter is a safe area. Beyond that, the CR knee will not function well. If you are a PS surgeon, then we have some more leeway. 4 millimeter to 5 millimeter of additional femoral resection is fine in a PS knee. If you are forced to excise more bone from the femur, 6 millimeter, 7 millimeter, then we may enter a situation where we need a constrained knee like a CCK or a TC3. And definitely if we end up cutting more bone from the distal femur, more than 9 or 10 millimeter, then it is better off putting a hinge, because the flexion gap will be unstable in that situation, and we need to compensate that by adding constraint. Now, when we are putting a hinge, by definition, we are eliminating the varus valgus movement in the knee. So there is obviously no mid-flexion instability, but we cannot chop off too much bone from the femur, even if we are planning to do a hinge, because that can we can still have a patella baha, and that in that situation the hinge also will not function well. So in most situations, 3 to 4 millimeter additional bone resection from the femur is safe. And if all that fails, then we come to a situation where we need to do a tenotomy of tight hamstrings. This is the last step. It is rarely required. Only in cases of very severe flexion contracture, 60 degrees, 70 degrees, which is seen in long-standing rheumatoids or sometimes hemophiliac patients. In those cases, we may need to do a tenotomy of the tight hamstrings. But we have to remember that the hamstrings actually protect the posterior neurovascular bundle. If you tenotomize the tight hamstrings and then you try to straighten the knee, you are going to put the posterior neurovascular bundle on stretch, and you can cause a neurovascular compromise. Fortunately, this step is very rarely required. Whatever we do, our aim should be full extension must be achieved on the operating table without any residual FFD as far as possible. So, but what if there is some residual FFD? How do they behave after surgery? So, fortunately, the natural history of flexion, the residual FFD after TKR is very encouraging. They actually have a tendency to correct. If it's less than 15 degrees residual FFD, we can expect almost a full correction at 1 year. And if the residual FFD is more than 15 degrees, at least some partial correction is expected over the period of 1 to 2 years. What is important is that if in the immediate post-op period, we find the residual FFD of especially more than 15 degrees, we have a window period of 3 months. In this period, the soft tissues are still pliable, and we can employ aggressive physiotherapy, supervised physiotherapy to correct this residual deformity. Any deformity which remains after 3 months is somewhat resistant for correction. So what is the routine post-op care after a FFD correction? Most important, if you are coming from a situation where we have a preoperative 30-40 degree deformity, then we have to be extremely vigilant. The deformity can come back if we are not careful. So we have to schedule frequent post-op visits, frequent follow-ups. Prolonged and supervised rehabilitation is a must. It is better to put the patient in a long knee brace or a night splint, because whatever correction we have achieved, we don't want to lose it by the patient keeping it in the position of comfort. Additionally, a simple thing to do is to put a thick pillow below the heel. And this will actually stretch out the posterior soft tissues, posterior capsule as well, and help in passive correction of the residual FFD. One thing that you should not do, suppose you notice a residual flexion contracture after surgery, the one thing that never must be done is to force the knee into extension, because we have a tremendous lever arm, the patient may be osteoporotic, and in that post-op period, recovery period, when the patient is still maybe under anesthesia, if we try to push on the knee, we can end up with a supracondylar femoral fracture. So rather than do that, what is important is gradual and passive knee stretching. Now, this is best done by the physiotherapists. They do it in the supine position, sitting position, prone position. They use different sort of weights, and a gradual correction is achieved. We can also give a contralateral heel raise or a shoe raise, which will have the same effect, passive correction of the posterior soft tissues by stretching. We may also try post-op serial casting for a few days in the window period. I have no personal experience with that, but sometimes in severe cases, it helps. So the take-home message is that pre-op planning is important. You have to look at the deformity. You have to look at the X-ray, look at the clinical picture, examine under anesthesia, and see exactly what we are going to require during the surgery. Second, we need to have an algorithmic approach during surgery. We look at osteophytes, look at the posterior capsule, see how much posterior capsule we have to release. You have to make a judicious decision if distal femoral resection is required, because once we cut more bone than required, we cannot go back. So we have to be very careful in deciding how much distal femoral resection that we do. Always try to upsize the femoral component. It always helps to minimize the mismatch between the femur and the between the flexion and the extension gaps. Aggressive physiotherapy after surgery, supervised physiotherapy, and repeated follow-up visits are important if you are starting off with a large flexion deformity. In most cases, most patients do well, and you end up with a happy patient. Thank you very much.
Thank you. Thank you, Dr. Rauth. Before we take some questions on the chat, let me start asking you a couple of questions.
Yes, sir.
So, do you think that this type of patients certainly require a very aggressive pain management protocol post-op?
The pain management is actually not much different from what we do routinely, adductor canal blocks or epidural analgesia or suppository or anything. Only if you try to correct it aggressively, if you try to push the knee, and then the patient may have more pain, and then we have to do something more for that. But in most cases, no, sir.
My second question is, if there is a FFD with stiffness, I think you mentioned some stiff knee also.
Yes,
so
sir.
In those cases, do we need some special approach like a quadriceps snip or anything?
Yes, sir. So FFD with stiffness, that is, if by stiffness you mean we are not able to flex the knee also, right?
Correct. Correct.
Yeah. Okay. So if you are able to bend the knee up to 60 degrees, then we really do not need to do any quadriceps snip or anything like that. And Z lengthening also is not required. It's going to weaken the quadriceps muscle. But if you are not able to bend the knee at all, if the knee is stiff in full extension or say 10-degree flexion or something like that, then we may need to do a quadriceps plasty or sometimes a Z lengthening. But we have to be careful, and we have to counsel the patient that the patient may have an extensor lag after this.
Dr. Vikram, do you think there is any role of preoperative physiotherapy in correcting the deformity? Will it help? The preoperative physio has any role?
Zero.
Okay. And you think that the best is to achieve the full correction on table only?
No, not at all. It was excellent talk by Dr. Rao.
Yeah.
Osteoarthritis, knee, you have to achieve 100%. Any inflammatory arthritis, rheumatoid, and so on, it is in several parts. You have fibrosis because of inflammatory process. You have fibrosed tight capsule, and you have shortened tendons of muscles because of muscular contracture. There are three parts. Now, once you correct the capsule, and once you remove all the fibrosis, posterior fibrosis, you achieve most of the correction. So say you are operating 90-degree flexion deformity or 70-degree FFD. You will come up to 30, 40, 45. And then you will have tendons. I never correct or cut tendons in last 29 years.
Oh.
They stretch out. Capsule will never stretch out. And we put patients in skin traction, and we tell patient to stay in a hospital for 15 to 20 days. They all are fully corrected. And I have done more than 150 cases like this. More than 90, 110-degree FFD. Young girls, severe rheumatoid, 22 years, 25 years, 18 years. And they get fully corrected.
Yeah.
But you don't keep fibrosis, and you release posterior capsule thoroughly. And posterior capsule is done from femoral side. It is easier, it is safer. So you push the tibia in full flexion back and elevate it with the curved osteotomy or periosteum. It will go back on femur. And once you straighten, you will get very good correction.
Correct. Dr. Rauth, you can see some questions there. Meanwhile, I asked Dr. Vikram another question. You can just look at the chat box. So, very severe deformity, Dr. Vikram, you said about 90-degree or so. Should we worry about the vascular problem after the correction?
That's what I'm worried, and that's why I don't cut the tendons. I leave it 30. See, tendons are tight muscles.
They will stretch out.
They will stretch out, and at the same time, vascular and neural structure will stretch out. So we never got the problem, because even if we corrected 110 or 100-degree FFD, we never got a neurovascular problem, because we were never very enthusiastic to correct it on table. I am talking very, very clearly for inflammatory arthritis. I am not talking about osteoarthritis. And in osteoarthritis, you never get such FFD.
Agree. Right.
And the last thing, there are certain neuromuscular problems, and you get 90-degree FFD or a 70-degree FFD where hamstring is overpowering the quadricep. Any patient undertaken for knee replacement with severe FFD, you should get EMG and CV done before surgery.
Okay. Right. I think that's an important clinical point to keep in mind. Inflammatory arthritis is okay, but otherwise you should look for the neuromuscular imbalance and make sure that you are not missing any neurological condition or overpowering of other muscles to cause the deformity. I think that's what
it's always safer to leave part of the deformity. As Sir said, it will stretch out.
Correct. Any questions there, Dr. Rauth? Have you seen?
Yeah. So, does pre-op traction works? Dr. Vikram Shah sir has answered that. No role of pre-op traction. Intra-op tips, yes, we discuss all that. The most important is posterior clearance, posterior osteophyte removal, and stripping the capsule away from the femur, not so much from the tibia. And what should be done for post-op residual FFD? We saw that we have to employ rigorous physiotherapy and gradually and passively stretch out the deformity. 20-30 degrees is generally not a problem. Over the next few months or 1 year, it will stretch out to a manageable level.
Again, I think it has been stressed by Dr. Vikram that usually we don't get that severe 90 or 100-degree deformity in OA.
Yes.
Those severe deformities are inflammatory conditions where you can afford to leave some FFD, which will gradually stretch out the tendons and muscle, as he mentioned. The osteoarthritis deformities are not that very severe, like 100-degree or so. But in osteoarthritis, you should try to correct the deformity and get a satisfactory correction on table, not like inflammatory. So I think there is a very clear difference between the two when you are dealing with on-table situation.
Yes.
Any other question there? I think there is one more.
Femoral upsizing can result in anterior overstuffing. How to tackle such situation? Okay, so here when I mentioned femoral upsizing, I am talking of anterior referencing. And when we are doing anterior referencing, we are actually playing around only with the posterior, only on the posterior side. We are not changing nothing in the front. So there is no question of anterior overstuffing. In fact, we are filling up the flexion gap by overstuffing. And another question, role of preoperative traction. Actually, it doesn't work. I think intraoperative release is the way to go.
Yeah, I think it has been very clearly also said by Dr. Vikram, there is no role of preoperative exercise to correct the deformity, but it is important to examine after the anesthesia. So how much correction, which Dr. Rauth has also mentioned, how much correction you have achieved on table under anesthesia. So that is usually very important to see the correction and the range of movements what you have on table after the anesthesia.
Yeah. And one question is hip or knee first? So if the patient has a hip deformity and a knee deformity, it makes sense most of the times to tackle the hip first, because if we do the knee, then hip can be difficult later on.
Yeah. All right. Dr. Rauth, anything when you have a FFD with the valgus, right?
Yeah.
Deformity, you briefly mentioned that point, but anything specific you would like to?
The principle remains the same. We should, when we correct a biplanar deformity, when we do a release on the lateral side, when we pie crust the IT band, we are contributing to correcting the valgus deformity. And at the same time, we would find that a mild flexion deformity which is coexisting also would get corrected. So we should not jump to excess femur resection right at the outset. We should leave that as a reserve. I think Dr. Vikram Shah will agree with me, sir.
No, you are absolutely right. 30-40% of severe FFD patients of rheumatoid and related diseases are having valgus also. And we approach valgus by anterolateral approach. Having said this, the most important part with severe valgus and severe FFD of rheumatoid, when you correct this, skin closure is a major problem, because the skin has shortened over the time, over the 15, 20 years, and you are not able to close the skin. Particularly rheumatoid valgus with FFD, it is very difficult to close, and you calculate beforehand that how much short skin you are going to have ultimately, because you have to close your knee.
Do you think in those cases sometimes you have to keep the help of plastic surgeon in a rare case?
The plastic surgeon are most fantastic people. They will come and put gastrocnemius on the other side. You don't want those things to happen.
Right. Okay.
So you calculate beforehand how you are going, because see, these patients are thin, lean, and no subcutaneous fat. And
I think you have to be careful in your closure, either take a loose stitches or
yes, and you should be mentally ready to put a release incision on the near posterior aspect so that the skin can come and cover your knee.
Correct.
We never required to do this thing, but you have to think about this before you start.
Okay. Right. I think there are no more questions there. Dr. Rauth, have you seen that? Anything else there?
I think we have covered everything. So.
Fine. Okay. So we are almost at 8:30. At this time, I must thank Dr. Vikram Shah, who has stayed from 7 to 8:30 all along both the talks and contributed with his comments and suggestions and tips. And I take opportunity to thank Dr. Pachore and Dr. Rauth for excellent talks. As I mentioned to all the colleagues, those who are there, that the next talk is on 9th of December. We have Dr. Vijay Bose and Dr. Nilen Shah as two speakers. Please spread this message as much as we can, as much as you can. We already created a WhatsApp group now where we have about 200 members and trying to send this message. So the new brochure, new flyer will immediately come into the WhatsApp group, and you can mark the date 9th December. Any questions you have, you can certainly put on those groups. We will try to answer from the experts. And if you are really very keen on any specific topic you need, that also you can put us on the group and we'll try to cover. Of course, with the help of all the seniors, along with me and Dr. Raja, we are going to cover the various topics during the course of the whole academic program of the year. I'm sure we will cover all the topics, and we have already been covering also. But still, if you are very keen on certain things, you can, without hesitation, contact us on the WhatsApp group and put your suggestions. We'll try to cover those. So with this, I thank all the speakers, Dr. Vikram Bhai, and all the executive committee members and my colleague, Dr. Raja, for this excellent session today. And looking forward to see you all on the 9th of December for the next session. Thank you and good night. Thank you.
Thank you.
Thank you, everybody. Thank you. Good night.
Good night.
Yes, sir. Thank you, Vikram.
Recording stopped.
Yeah.